As we all know that safety, wear personal protective equipment when handling patient samples as usual. In this case, lab coats, gloves, masks. Dispose all waste material in accordance with the local guidance and the lab waste management, that the SOP. Refer to specific safety data sheets from the manufacturer on hazardous reagents you'll use in the procedure. I'm going to start with FNA. In this case, as we all know that it's a procedure done to obtain diagnostic cellular samples through a fine needle under negative pressure. It is useful in lesions that are easily palpable, subcutaneous soft tissues, tumors, thyroid, lymph nodes, salivary glands, and breast. At Scan Lab, this procedure is ultrasound guided. Now, as a tech, you need to be able to assist the pathologist who is conducting the procedure with the necessary support. Requirements. We do require needles, in this case, a standard gauge being 21 to 24. That is around 1.5 inch needles. For small subcutaneous lesions, inch 23 gauge needle is ideal. A deep-seated, like breast lesions, longer and larger needle is required. For children and for vascular organs like thyroid, finer needles are required. Syringes, standard disposable plastic syringe of 10 ml are used. 5cc syringes can be used for vascular organs like thyroid. Syringe should be of good quality and should produce good negative pressure. In this case, we mean that the needle, the standard should be good, in that you don't pull and then the syringe disconnects itself or it breaks and all that. Oh, something is off. I don't know what's up. I'm sorry for this, guys. Let me see what is the... I'm sorry, I don't know why that happened. Continuation, you do need slides. In this case, you need frosted slides of good quality for you to write well as you prepare your smear. Slides should be clean, dry, transparent, and grease-free. You also require a fixative. In this case, you require 95% ethyl alcohol and absolute methanol are recommended. One, you do require 95% ethyl alcohol to fix direct smears. You do require absolute methanol to fix air-dried slides. So you need to have that separation, or rather the reagents, 95% ethyl alcohol to fix the direct smears. And then the ones that you give time to air dry, they are the ones that you're going to fix them in absolute methanol. Other supplies in this case will be test tubes, pencil for marking, alcohol swabs for skin adhesive dressing, then gloves and etc. Seems like I have an issue with my network or something. I don't know what is happening. Aspiration procedure. Now you have assembled your requirements. Steps to be followed before performing the aspiration. The relevant clinical history. radiological findings, provisional diagnosis, etc. Site of FNA must be clearly stated. In this case, let's say you're doing a thyroid as a site. You need to capture that, the procedure, the clinical history, and then the lesion to be palpated and its suitability for aspiration assessed. The appropriate needle is selected accordingly. Oh, my internet. Okay. The procedure must be clearly explained to the patient and consent cooperation ensured. Before starting the procedure, ensure that all the required equipment, instrument, and supplies are available. In this case, you will not be telling the pathologist or whoever is conducting the procedure that this is missing. I need time to go and look for needle. I need time to go and look for slides. You need to assemble all the requirements needed. All universal precautions should be followed during the procedure. Steps to be followed in the actual performance of the aspiration. Positioning the patient. FNA is usually carried out with the patient lying supine on an examination couch. In this case, we're saying that the patient lies on the couch facing upward. That is, you lay the patient on their back facing upwards. Then step number 2 is the immobilization of the lesion. You clean the lesioned area with an alcohol swab. Fix the lesion between the thumb and index finger on the left hand with the skin stretched. In this case, you're using your left hand so that you can set your right hand free. That is going to be used to manipulate the lesion, or rather to pierce the lesion. Now, grasp the syringe with the needle attached to the dominant hand and introduce through the skin into the lesion carefully and swiftly. Continuation, you need to adjust the needle according to the type of lesion. Now, after doing that, when fluid is aspirated, its color, consistency, and amount should be recorded in the requisition form. Why should you do this? Because this now dictates how the diagnosis is going to look, or rather the pathologist can relate the two and give a diagnosis depending on what he or she is seeing on the slide. Observation while doing the aspiration regarding the site, size, consistency, that is solid, cystic, soft, sclerotic, vascular, must be correlated while interpreting the smears later, so should be captured in the request form. Let's say you said that the lesion is cystic. So when the pathologist is giving out that result, depending with the clinical history that was captured during a sampling, will trickle down to reporting a cystic lesion, measuring this by that and all that. Now, in this case, what I've explained is that you can see here the left hand are trying to palpate the lesion like that, placing the lesion in between two thumbs, that is the thumb and the index finger, and then having a needle and then a needle with a syringe, then trying to pierce the lesion. Other images showing how to access a lesion using ultrasound band, whereby we're targeting the nodule here, this being the nodule, and being an ultrasound guided, so that when you're trying to access the lesion, you cannot miss or rather you can not injure other organs. The nodule there on a thyroid. Another image here showing the same. I do also have image 2 here, ultrasound guided as well, a lesion here, and then the nodule, that is the lesion, and then the organ. So through this, having an ultrasound guided here, you able to access the lesion without missing it. Breast, image 3, again, ultrasound guided, the lesion here, in this case, being a breast lump. So you can aspirate whatever is inside here. And remember, once you want to aspirate, it doesn't mean all the time what is there is a fluid. No. You need to make sure that what you have aspirated definitely contains the cells. You will find that most of the pathologists, someone is having other techniques like piercing inside the lesion, trying to reposition the needle so that the lump, or rather the lesion, can shed cells, which are now aspirated into the syringes and now used to make the smear. Now, after doing that, you have now aspirated your sample. You move to the next step, which is now smear preparation. Now you disconnect the syringe and fill with air by withdrawing the plunger. Then reconnect the needle with syringe and push gently a small drop of aspirated material onto the clean slide. Make a smear by touching the sample with the spreader, slant, then push forward with quick motion and fix immediately in 95% ethanol. I said that the slides that we are going to fix immediately, they are the ones that we are going to use when we are doing the PAP staining method. The ones that we are fixing with absolute methanol, they are the air-dried slide, which we are going to use when we are doing a special stain. In this case, I'm referring to ZN, I'm referring to GEMSA stain, like that. So in this case, after making the slide, let's say I've prepared 6 slides rather, I will make sure that I have, let's say 3 slides for PAP smear that I'm going to fix them instantly because they are the one I'm going to fix using the PAP method. Then 2 slides, I decide to stain GEMSA. So I'm going to air dry them together with the ZN one, then later on fix them using absolute methanol. So so far, that is that is FNA side. Now we do have the PAP smear side. In this case, a PAP smear, we're going to complete the presentation, and then from there I will take those questions. So a PAP smear is a screening test used to detect potentially precancerous and cancerous process in the endocervical canal. And then we do have the transformation zone. In this case, this is the area in between the ectocervix and the endocervix. That is what we are calling the transformation zone of a female reproductive system. It detects early cancer of the cervix and recommended to all women who are sexually active at least 3 years after onset of sexual intercourse. We do have 2 types of PAP smears. We do have conventional and then thin prep. The conventional, this is the most practiced, whereby you collect the sample, then smear it on a slide. So that is basically what we're going to tackle. So you will find that there are conditions that may render a PAP smear test unsatisfactory or interfere with the cytological examination. One, we do have improper fixation or drying of the smear before fixation. We have said that if you want to do a PAP method staining, or rather, you need to fix your slide immediately. The other one is excessive use of lubricating jelly on the vaginal speculum. QI jelly is used when someone is inserting speculum into the vaginal canal. So you do not apply too much. So excessive mucus can also interfere blood or purulent exudate. In this case, if there is a lot of mucus, you need to wipe the patient. If there is blood, you need to assess why there is blood. Reason being, you cannot do a pap smear when the patient is on their menses. Why? That is going to interfere with the reporting. What the doctor will be seeing will only be hemorrhage, in this case, signaling that there was blood. But you also need to be keen to evaluate where is this blood coming from, because a patient might be having a mass, and most of the masses tends to bleed on touch. So when you touch a mass, tends to bleed, so that one needs to be catered for. You need to capture that on your clinical history, that the patient has a mass that looks like this, that bleeds on touch. The other thing is inadequate sampling of the transformation zone. Let's say you have not sampled well. Slide material too thick or insufficient. Most of the time you find that someone, after collecting the sample, when you smearing the slide now, you tend to smear on one point. When you do that, you're going to make those cells to overlap on one area. In this case, the doctor will not be able to pick the diagnosis, yet you'll be seeing cells piling. The reasons for rejection of specimen include incomplete or missing requisition form, prepared slide received beyond repair for conventional pap smear. Most of the time, a slide can break, but there is that need of trying to reconstruct the slide so that you can pick a diagnosis, or rather than subjecting the patient back to the same procedure, doing recollection and all that. You can also reject a sample if is mislabeled or unlabeled slide. Continuation, all conventional pap smear slides must be clearly labeled with the patient first and last names, as well as second identifiers, such as the patient age or visit number. In this case, let's say we do have two patients sharing same name. So if you tend to write, let's say Agnes Njoki, and then you happen to have two Agnes Njoki, and then you subject those slides to the lab like that, then someone can end up confusing. But if you pick the age of that patient, it is very rare for patient to share age. But that one, you go extra mile as well. If they happen to be sharing that age, you can give them a visit number. In this case, we all know that the patient cannot share same visit numbers. So the visit numbers will be used to distinguish these two patients. To ensure thorough and complete interpretation, please include the patient clinical history on the requisition form as follows. You can capture the age, date of the last menstrual period is required when you are doing pap smear, number of lives and stillbirths, that is the para, the family planning method used or any medication, abnormal pervaginal bleeding, discharge or postcoital bleeding, previous abnormal pap smears, specify previous abnormality. In this case, this raises now concern that the patient has done, let's say, 5 smears or 2 or 1. Then you need to capture how was the result. Was the result positive? Was any intervention done? So that will make the pathologist who is examining the slide, it will raise eyebrows. Then the pathologist will be able to do due diligence. You can ask the patient any pain around the pelvic areas. Why? Most of the time, patient might be having, let's say, a mass. And then that might be causing that pain to be there. Then abnormal or rather cervical cervix, or rather access the cervix during sampling. In this case, you need to describe how the cervix is looking like, what you're seeing, because you are there with the patient. You need to describe that this is how the cervix looks like. Or rather, I've seen a mass measuring this by this. The mass looks brown like that. There is a mass that bleeds on touch, something of the sort. Then that will be used by the pathologist now to make diagnosis as well. Specimen collection instructions. You avoid collection of samples during the patient menstrual period. That one we have mentioned. The recommended days is that 10 to 20 days after, when the patient has PV bleeding as well. If the patient has an hysterectomy, submit smear from vaginal apex, or rather what we call the valve smear. You'll find that a patient hysterectomy was done. Now you don't have the cervix to sample. So you need to collect a smear from the vaginal apex. When you're doing PAP smear, there are materials that you do require, one being the cervical broom, or what we call the cyto brush, spectrum, frosted slide, fixatives, gloves, good lighting, a coach, and then a KY jelly that facilitate ease of insertion. Procedure: label the PAP smear kit with the patient name, age and visit number, as we have said. Then after that, you need to visualize the cervix with the speculum in situ under adequate lighting, so that you can see, or rather you can assess how the cervix looks like. In this case, you can pick other things like that. Discharge, how is the discharge looking like, something like that. KY jelly may be used to insert the speculum in position. Next is insert a cervical broom and twirl around 5 times in a clockwise direction with the central longer bristles in canal. I'm going to show that. Fix the smears immediately by applying 95% ethanol. And then the slide should be fully fixed. We have said that these slides we are preparing here, they are going to take the PAP staining way. So you need to fix them immediately. You don't give them chance to air dry. In this case, this is what I'm saying. This is the brush that is used when someone is doing PAP smear. We do have the shorter bristles, this one, and then we do have the central part here having the longer bristles. In this case, you will find that, as I said, we do have that transformation zone. So this longer bristle at the center will sample the endocervix. that is inside. And then this one will sample the ectocervix. In this case, like in this image, you see that the longer bristles are inside and the shorter bristles are outside, making contacts with the ectocervix part of it. So once these longer bristles gets into the os, this smaller, this circle here, it's called os. So when the longer bristle goes into the os, that is when now you twirl, or rather you roll you brush like this, and you do it 5 times. This another image here. Rotate clockwise 5 complete revolution. In this case, you will have sampled the transformation zone here. So you will sample in and out. A diagram here showing the same. This is how you see it. So the speculum being here, then the PAP smear brush like that. Then here, this is where you are going to sample. The longer bristles, we have said that they will sample the transformation zone. And then the shorter bristles will cater for the ectocervix. Rejection criteria for all the samples, we have said that sample without request form. Inadequate sample unless otherwise. Client on their main says you don't collect samples, slide without request form, and then mislabeled slides. So that is that. Unless we do have questions, I will take them.
Thank you, Tua, for the presentation. Thank you so much. Members, you can applaud Mutua for the clear presentation, even as we embark on the questions. And thank you also, members, for participating in this. I've seen your questions, so many, and contributions. Mutua, I will get you the questions in a while. Just
Okay.
10, 24. Okay, fine. Thank you, members, for the appreciations. Now, to the questions that we have here, the first question is coming from Humphrey Mbugwa. Humphrey Mbugwa asks, what determines the size of needle to be used? So Mutua will start with that. What determines the size of needle to be used?
One, what determines that is that the site of the lesion or the organ where that lesion is. Why? There are organs that are tender. If you happen to pull with a lot of pressure, it can cause more injuries or damages to the patient.
Thank you, Mutua. Well noted. The next question is from Evelyn. Evelyn asks, does the angle of a syringe during piercing of the lesion considered? Does the angle of a syringe during piercing of the lesion considered? Back to you, Mutua.
Once you have immobilized the lesion that you want to assess, or rather to aspirate the sample from. Once you get in, there is that bit of shifting, or rather changing the position of the needle so that the lesion can shed cells. Now, those cells are the one that you're going to aspirate. So that one doesn't matter. The angle of the needle doesn't matter at all. As long as there is enough materials to be aspirated. That one doesn't matter.
Okay, thank you. And Alex had the same question, Alex Gitonga, who had asked what angle is recommended when taking an FNA sample. So Alex Mutua has answered the angle doesn't matter. So the next question is from Lawi Mwangome. Lawi asked, for FNA, he had a pathologist who was instructing him to prepare squash smear immediately. So he asked if you could expound on that. So for him, his case, the pathologist used to instruct him to prepare squash smear immediately for FNAs. So would you kindly expound on that, Mutua?
The pathologist will instruct you to do so because if you do take time, the sample is going to clot. So what you need to do is that you need to prepare the slides immediately. But once you do that, there are those slides that you're going to fix them immediately. And these are the slides that are going to be stained using the PAP method. There are those slides that you're going to stain them on either special stain, one being ZN and GIMSA. This one you don't need to fix them immediately, or rather you don't require ethanol to fix them, but you require absolute methanol. Remember, the essence of preparing the slide instantly is to prevent the sample from clotting.
Thank you, Mutua. The next question comes from Wanjiku Naomi, and Wanjiku Naomi has two questions. She asks, who's eligible for PAP smear and what's the age limit? Back to you, Mutua.
Thank you for that question. One, in PAP smear, there is no age limit. Reason being, for a doctor to request for a PAP, there is something that the doctor is trying to suspect. So you cannot turn the patient back based on that. There is no age. As long as the patient is above the 10 years, that is the 13 years and above, that patient is eligible for that. Or rather, if the patient has reached that age of the menstrual and all that, that can be done. But based on the clinical examination, the doctor can request a PAP smear to any age group, but not the young ones. The other thing is that there are those patients whom they can be rendered from taking the test. Why? Let's say the patient has been on a follow-up at least for 5 PAP smears. And then you find that all of them, they are negative. In this case, taking a PAP smear can be seized.
Oh, okay. Thank you, Tua. Next question comes from Alex Gitonga. Alex is asking if you could please talk about rejection criteria considering the invasive nature of taking FNA samples. So is there rejection criteria considering the invasive nature of taking FNA samples?
One, we need to understand this. Once we say that, we need to fix let's say, FNA slide immediately for the PAP method. And it happens that someone didn't fix those slides. Once the slides reaches the lab, they are going to be fixed using ethanol, but that will be noted down. Why? The morphology of the cells will not be preserved as it's supposed to be. But once you fix them instantly, then the morphology of the cells is preserved. So there is that bit of trying to salvage the situation whereby you don't reject, you don't say like, this one cannot be tackled. And that's why I said somewhere that sometimes we are forced to reconstruct the slide. Let's assume that the slide broke down. So you need to try as much as possible to reconstruct that slide, at least for the pathologist to pick diagnosis.
Okay, thank you for that.
Yeah,
Humphrey.
but we also need to be very keen. You will find that sometimes I have two patients for FNA, and then I submit all the slides wrapped in, let's say, in a tissue paper, and none of the slide is labeled. In this case, if I happen to mix those slides, there is no way out. Definitely you are going to reject that sample without shortcuts, because you cannot close eyes and pick this one looks like that and all that. There is that bit of being keen so that you can prevent such scenarios to occur.
Okay, well noted. So Humphrey Mbugwa again asks, during aspiration, how would you avoid withdrawing blood sample in a blood vessel, especially in cases where the area to be aspirated is surrounded by blood vessel supply, that i.e. avoiding vein puncture instead?
One, now that will come to the pathologist's side who is doing the procedure. At least we said that, first of all, you need to assess. You need to assess the lesion. And then that's why we are going that extra mile of using the ultrasound guided, whereby you can visualize the lesion and see when you're trying to the part that you're going to use when you are trying to access the lesion. So there is that bit, or rather now that can be catered well by the pathologist who is doing that procedure. But you need to assess your where the lesion is seated. You need to either use the ultrasound guided and all that.
Okay, thank you, Mtua. The next questions come from Paris Njoroge. Her question is, you stated that you reconnect the needle with the syringe, then make a smear. Is recapping advisable?
The reason of reconnecting the syringe with the needle is that at least to release smaller drops of the sample compared to if you just push it without a needle, then the sample might flow on the entire slide. Yes, we know that recapping is not allowed to avoid injuries and all that, but you can be keen and do that. Thank you.
Thank you, Mtua. Wanjiku Naomi asks, do we do FNA to all palpable nodules? And then
Sorry?
she had, do we do FNA to all palpable nodules? That's her first question. The other bit is, that means that if someone, I think this is just a comment, that means if someone has had total hysterectomy, you're still supposed to do the test, or it's a question in there. So do women who've done total hysterectomy still do PAP smears, and why? Will it still give quality samples for processing, considering the fact that you haven't sampled the endocervix? And what's the essence of sampling the vagina? So maybe you can take those, and then I will read some more from Naomi.
Okay. One from Naomi, she asked that do we do FNA or only on the palpable lesions? One,
Sorry,
we have said...
Mutua.
Sorry?
On all, do we do FNA on all palpable nodules? She asked if we do on all, any palpable nodule that you come across, you do FNA. Is it true that we do FNA on all?
Now, that one will be guided by the clinician who is requesting that FNA to be done. But if there is that suspicion, remember we are doing FNA because we are suspecting something. In this case, we are suspecting malignancy. So if the clinician wants to rule out or rule in, then the clinician will give that guidance. Do FNA for this. Why? Because I'm suspecting this and that. So yes, based on the request from the clinician.
Okay, and then her other question was about asking, should we do FNA on, PAP smears on women that have had total hysterectomy, and why? And she's trying to explain there, will it give, also asking, will it give quality samples for processing, considering the fact that they don't have, you haven't sampled the endocervix? And what's the essence of sampling the vagina?
I've not gotten your question well. So kindly, I don't know if you can...
Naomi is asking, is it okay to do PAP smears on women that have had total hysterectomy?
Oh, all right. Thank you. I got your question. One,
Okay.
now, based on the first reason, why was the hysterectomy procedure done? Was it done because of the cancerous cells? Then, if yes, then the doctor can recommend that. Because if those cells, if the hysterectomy was done due to cancer bit of it, then there might be cells that will be on the vaginal apex. And that's why we are sampling the vaginal apex in this case.
Okay, I hope Naomi has been answered. She also asked, what's the essence of sampling the vagina? Oh, considering the cancer that was that had affected the patient. I understand, I get it. I hope, Naomi, you've been answered on that part also. I'll move on to Evelyn Omondi. Evelyn Omondi asks, can PBF, I guess this is peripheral blood film, test used to diagnose cancerous cells in early stage? Mutua?
This is a broad, that is a broad question. But to my knowledge is that PBF can be used at least to pick signs. In this case, let's say a patient did a PBF and then white blood counts was high. And then when the pathologist, or rather the clinical now pathologist, is trying to examine the slide, finds that, yes, there are cells like blast cells. Then the clinical pathologist will advise either to do a bone marrow. Now the bone marrow will be processed the histology way, H&E will be done. Then later on, the pathologist can request for IHC to be done to confirm this. Remember, if a patient is suffering from, let's say, blood cancers, there is a way you can do a bone marrow and then do an IHC like CD138, which will now confirm, yes, for sure, this patient has this cancer. So yes, it's possible.
Thank you, Mutua. Wanjiku Naomi had asked a question, and Charles Koipa answered it, and he answered it well. So I'll just read it out and I read the answer so that Mutua can give an okay, so that we move on to the next question. So Wanjiku had asked, after how long should one get a PAP smear? Repeat, especially routine check. And Charles Koipa answered, for routine checkup, it's normally done yearly, but in case the first PAP smear was unsatisfactory, for reporting due to insufficient sampling, recollection can be done anytime, provided the patient is not on her monthly period. Mutua, I would want to believe that you agree with the answer Charles Koipa had given. Koipa, sorry.
Yeah, sure. He has given the way it's supposed to be. So that's okay.
Thank you, Naomi, and thank you, Charles, for your contribution over there. Naomi, Wanjiku Naomi, here again, you can only know that that sample is inadequate while examining microscopically. So her question is, how will you know that the sample is inadequate soon after being received in the lab? That is before you start processing. Mutua?
One, I think now this will be based on day-to-day routine. In this case, let's say someone did a procedure, and then after submitting the slides to you, or rather to the lab, you find that the slide is so clear. Then you can just be sure that even the pathologist, after staining and submitting the slide to the pathologist will not pick anything. So that slide will be evaluated, yes, but a comment will be given that diagnosis cannot be picked, reason being the sample was insufficient, so consider doing a recollection.
Thank you, Mutua. Crispus Mulongo asked, for FNA, we as lab technologists, are we allowed to collect the samples?
We are not allowed to collect the samples, but we are there to assist whoever is doing the procedure, in this case being the pathologist, or rather, yeah.
Thank you, Mutua. Eliakim Maliki asked, what guidelines do we consider for the type lesion to perform FNA? What, if I would interpret this, is what guidelines does one consider for the different types of lesions that are there for you to carry out FNA?
Okay, one, this will come from the clinician side. Before the patient is sent for FNA, other procedures have been done. Let's say the patient maybe has been monitored for a long period of time, and then there is that on and off and all that. So the doctor decides now from the clinician side that this now requires FNA for us to rule out. So that will originate from clinician side.
Thank you, Mutua. Calvin Sokech asked, what is the essence of measuring a tissue that has been extracted and even describing it before processing it for examination? So what's the essence of measuring a tissue?
What is the essence of measuring a tissue?
Yes.
The essence is that, let's say we're tackling a tumor, and then in this case, a breast tumor. Before you do a procedure, first of all, I've said that there are other evaluations that are done. In this case, the radiology bit of it. So when you do a radiology, you will see that there is a mass. Step number 1, there is a mass measuring 2 by 3 by whichever. Now, then from there, you don't direct skip to doing a surgery and all that. So you go step by step. You have seen a mass. You confirm it with other tests. In this case, you do, let's say, an FNA. From there, you can do a core biopsy. If you confirm for sure this is now tumor, you can do what you call mastectomy if it was breast. But now, sometimes you will find that this patient was on neoadjuvant. So treatment was initiated. But before treatment, the tumor size was 10 by 5. After treatment, the tumor size is 15. So you will use that to say this treatment didn't work. But if you did chemo and then you managed to shrink the tumor from 10 to 5, then you can say that treatment has worked. Or rather, you have tried to control the aggressiveness of this tumor. So that essence of giving dimension is needed on that bit. And again, a tissue can be submitted to you. A pathologist knows that, or whoever, or the surgeon knows that the surgeon collected 5 cores. Let's say 5 breast cords. And then you come on your end when you are doing grossing, you say that you are seeing only 1 core. Where is the 4? So that essence of mentioning the size, the number, is required on that bit.
Thank you, Mutua. Lawi Mwangome. Lawi had asked a question which Wanjiku Naomi responded to. Thank you, Naomi. That is it. Some facilities, yes, allow the cytologist or pathologist to report, and some facilities do not allow. So it depends on the facilities and the pathologists that are at that center. So our next question is from Robert Milgo. Robert Milgo asked, what's the lifespan of a fixed smear? What's the lifespan of a fixed smear?
Okay, that question it's a bit open. When you say what is the lifespan of a fixed smear, remember the essence of collecting the smear, you want to stain it. Now, unless the guy wanted to ask that, how long can you keep that smear? Then I will say based on the organization policy. In fact, in this case is nowadays required by the law, whereby you're supposed to keep at least the slides, you keep them for 10 years. The blocks, you keep them for at least 10 years.
Thank you. Thank you, Mutua. I think that there are so many questions, so I think we will try and rush over them so that we try and answer all of them. The next question is from Margaret Nuna. Margaret asked, what factor during specimen collection lead to unsatisfactory?
Sorry?
What factor during specimen collection lead to an unsatisfactory?
Basically, I'll just sum it to one word and say, one, sample can be insufficient based on the competence of the tech who is doing the procedure. That is one. Or rather, the lesion being small in a way that you cannot get enough specimen. Sometimes the patient can be so uncomfortable in a way that you cannot collect enough sample to be examined. So there are a lot of scenarios that can lead to insufficient of the sample. But most of the time, sometimes it can be caused even by the condition of the patient. Why? Because let's say, like the way we were saying that you examine the cervix, you find that there is a mass protruding or rather occupying the entire cervix. In this case, you're going to sample sides of mass, and some of the masses tends to bleed when you touch them. So you're going to at least sample just as you can, but your description on the request form in this case will carry the day. The pathologist examining the slide can reach out the clinician and say, there is either this seen when doing the procedure. So something else needs to be done. In this case, you are trying to direct the clinician on the direction of taking a biopsy. Yeah.
Thank you, Mutua. Rugut Kipyegon asked, which patient factors can interfere with PAP smear accuracy? And his second question is, what are the primary indicators for performing a PAP smear in routine cervical cancer screening? Back to you, Mutua.
Kindly, on the first question.
Which patient factors can interfere with PAP smear accuracy?
One, we said that there are factors to consider before doing a PAP smear. One, you have to ask the patient if they are on their menses, because once you do that, the accuracy of the report will not be achieved. Why? Whatever the pathologist will be seeing will only be hemorrhage. Two, a lot of discharge. A lot of discharge can obscure you from collecting samples of importance. So by doing that, that can contribute to that. Rather, the diagnosis will not be picked. Second question, kindly.
Second question was, what are the primary indicators for performing a PAP smear in routine cervical cancer screening?
Now, when you say routine, that question, I'll just say this. if you say that you performing a PAP smear routinely, you don't have that criteria of selecting patients, if I can say so. But the clinician on the other side, depending with the clinical history, what the patient has raised, then the clinician will decide to take a PAP smear or not.
Okay, thank you. Paris Njoroge asks, what's the TAT turnaround time for PAP smear results?
That will be lab-based. In this case, you will find that there is a lab that has numbers. So they will do as per their way of doing things. So you'll find that lab X says that the TAT for a PAP smear is 5 days. Why? Because maybe they have numbers and all that. Or you find that there is another lab saying that their TAT is 10 days. So there is not that specific established TAT for PAP smear, but that is lab-based.
Thank you, Mutua. Elizabeth Paul asks, how does the size of lesion important as part of reporting? How does the size of lesion important as part of reporting? Elizabeth
Remember
Paul.
when you are sampling and it happens to be cancerous. Now, if that mass measures, let's say 3 or 4 by something, the dimension, and in this case, the first dimension, when you say 4 by 2 by 3, the first dimension stages the patient from stage 1 to stage 2 or from stage 2 to stage 3. So size is important for that. Remember, when pathologists are reporting the histology part of it, they do have a guideline that says for a specific organ, for let's say thyroid, a tumor measuring 4, by default, stages this patient to stage X. So that size is needed to aid the pathologist as far as staging is concerned.
Thank you, Mutua. Next question is from Wanjiko Naomi. And I hope, Frederick, you are noting, you had requested for people that will really participate. Wanjiko Naomi should be on that list. I vote for her. So Naomi asks, how many slides are you supposed to prepare for FNA? Is there any specification or 4 slides fixed and 2 air dried are enough? So she asked, how many slides are we supposed to prepare for FNA?
There is no specified number that you're supposed to achieve. But sometimes you'll find that it is very difficult to get enough sample for you to prepare so many slides. So there is that, I can call it, there is that bit of reasoning. In this case, you can reverse James's slide to Zden slide, but you cannot reverse PAP smear, the PAP stained slide to Zden. So if you happen to get only 3 slides, you can choose 2 to be used for the PAP staining way. Then 1 can serve for GIMSA. You decolorize the slide after reporting, then you do Zden. By doing that, you'll have saved the patient with a lot of pain, a lot of recollection and all that. So there is no established number to achieve.
Thank you. Thank you, Mutua. Joy Mwendwa had asked a question. which has been responded also by Lillian and no, Joy had contributed an answer, where Lawi had asked a question and Lillian emphasized on what Joy had explained. Joy had said, small addition regarding age group, pap smears are collected from ladies who are sexually active. And Lillian had also added and said, pap smears are collected from sexually active ladies. And in that regard, Lawi Mwagome had asked, can a pap smear be collected from an adolescent virgin girl who is above 18 years? This is Lawi from Garissa. And Joy and Lillian have answered Lawi. So they are collected from sexually active ladies. Wanjiku Naomi, you see why I vote for Wanjiku Naomi? So she has another question here. What about the age limit? What exactly is the highest age that one can do pap smear, especially for routine checkup? Don't we have a maximum age limit? That's a question, the age limit.
Okay, I've been getting this question so much when clients walks into our facility, and I happened to ask one of our pathologists the same question: what is the cutoff for pap smear collection? But this is the feedback she told me, that there is no cutoff age for pap smear, because the clinician on the other end is suspecting something. But if this patient had done 5 consecutive pap smears within, let's say, 5 years, this patient can be rendered from collecting a pap smear, because at the end of the day, if they are consecutive, then you can rule out. So there is no that cutoff age limit.
Thank you, Mutua. There are still some more comments and questions, and members equally have contributed in answering some or almost the remaining questions. Paris here had asked, is it advisable to conduct pap smear test to postnatal mothers? Maybe you can take that one.
Sorry?
Is it advisable to conduct pap smear test to postnatal mothers?
Again, I will say that this will now this will be guided by the clinician on the other end. But ideally, it is supposed to be, pap smear is usually only performed a minimum of 6 weeks after birth. That is the ideal, how it's supposed to be. But sometimes you will find that clinician can request for a pap even before that time, because maybe the clinician is suspecting something. So you cannot say, no, I'm not doing it. But ideally, it's supposed to be 6 weeks after.
Thank you, Mutua. And I think this will be the last one, though it has been contributed also by some members. Nancy Kemunto had asked, can anesthesia be used during FNA, especially if the nodules are very painful or located in sensitive areas? Mutua?
Based on, I've never come across that one. Maybe I can inquire and give feedback, or other members as well, they can contribute on that, because I've not experienced that.
Yeah, some members have contributed, and yes, they said lignocaine is normally injected at the site prior to collection. Local anesthesia can be precise. That's by Wanjiku Naomi. So yeah, they say, yes, it can be used. So thank you, members. More questions which have already been answered by members in the forum. Like Kelvin said, asked, why is it that laboratory personnel not allowed to handle sample of FNA and PAP Smear, however, that all have undergone histology class and practicals, even reporting peripheral blood film reports. And Wanjiku has reacted to that and given Calvin's a good answer about that. I had seen somewhere else where Wanjiku again said, I think Mutua can refresh on this. Why do we do pap smear and at what point can a clinician request it? Note, this is besides self-routine check request. So, and Charles Charles Koipa had reacted to that and given his suggestions. Thank you so much, members. Thank you for keeping the chat section warm and active. And I believe our presenter has tackled almost all the questions. Maybe this last one, so that we don't close it up there. So what are the quality control put in place when carrying out the FNA? So John Kuche asks, maybe you'll take this last one. What are the quality control put in place when carrying out the FNA? Sure.
One, this, after preparing the slides, this can only be picked by the pathologist who is examining the slide. At that bit, the pathologist can evaluate the staining quality and then give feedback. You will find that there are labs that do have what we call a slide dispatch forms, whereby the clinician do confirm that the preparation of the smears is okay, the staining is okay, the fixation is okay. So that is the only way we can assess that. But now, let's say you in a platform whereby, or rather in a lab whereby you're dealing with accreditation bit of it like KENAS, then the KENAS will now check the documentation. Do you have the documentation? Do you have that? How can you support it? How can you prove it? Then the quality part of it now is catered on that end.
Thank you. Thank you so much, Mutua. Thank you for that elaborate presentation and even tackling all the concerns of the participants and answering them appropriately. Thank you so much for taking your time even to prepare, and besides your busy schedule at your workplace, even making time to be here and present on this topic this evening. Thank you so much. We really appreciate you. Thank you, members, for being here, taking your time to be here, to listen, to learn, and even to ask questions and to participate, and also to contribute even to the questions that have been answered here. You can applaud yourself. You can throw flowers to Mutua for the good work that he's done. And LMSK, we really appreciate you for putting everything together, working out to put everything together for us to be able to meet here, to learn even as we grow in our profession and learn more every other day. We're looking forward to seeing you tomorrow for our next exciting and educative seminar with a fresh topic tomorrow. So let's see you tomorrow. Follow us on the LMSK YouTube and join the LMSK WhatsApp group for more updates on how to get your points on how, and many other answers that you need to be tackled will be tackled there. Thank you, members. I will want to bring this to an end. See you tomorrow. I appreciate all of you.